Welcome back to Val and Mark's M2 show. I'm Dr. Mark Sanders.
And I'm Dr. Valerie Masuda, and today we're talking about one of my favorite things.
Deprescribing?
Exactly. Nothing gets me more excited than stopping medications.
When reducing a med list feels like winning the lottery.
Honestly, if I see someone going from 19 pills a day down to 8, that's a great day.
So today's episode is really about deprescribing in M2 care, minimally invasive, symptom focused care.
And I think it's important to say this clearly. Deprescribing is not giving up. We're not withdrawing care, we're shifting the focus.
Instead of how do we prolong life at all costs, we start asking how do we improve quality of life? How do we reduce treatment burden? How do we help this person feel better?
And sometimes the most compassionate intervention is actually stopping something.
Particularly when someone is frail, declining, or nearing end of life. Because the evidence we use for many chronic disease medications often doesn't apply to frail elderly patients.
Most guidelines are based on healthier adults who are expected to live long enough to benefit from the prevention. But if someone's prognosis is months or short years, we need to rethink whether those medications are still helping.
One thing that I liked was the idea of the M2 pause.
Yes, pause before reacting.
Patient becomes hypoxic overnight. Before ordering the entire CT scanner catalog, stop and ask, what are this patient's goals?
Exactly. Is this an easily reversible problem that aligns with their wishes, or are we escalating invasive care that won't change the outcome?
I think we've all seen patients who ended up getting blood work every single morning for weeks.
Daily CBCs on a 94-year-old who just wants to go home.
At some point, we have to ask, am I treating the patient or am I treating the lab value?
Let's talk about blood pressure medications.
Ah, yes. The classic 92-year-old with a blood pressure of 102 over 58 and still taking four antihypertensives.
And then everyone's surprised they keep falling.
Exactly. Blood pressure naturally declines near the end of life, especially if frailty, dementia, and heart failure.
So in M2 care, we often liberalize targets. Sometimes a systolic of 150 or 160 is completely reasonable.
And if they're dizzy, orthostatic, falling, or exhausted, deprescribing becomes a quality of life intervention,
Diabetes is another huge one.
especially when somebody has an A1C of 6.2 and they're 89 years old.
And they're having hypoglycemic episodes because we're chasing perfect sugars.
Meanwhile, they're confused, falling, and ending up in hospital.
Exactly. Tight glucose control in frail elderly patients often causes more harm than benefits.
So instead of tight control, the goal becomes avoiding symptomatic highs and lows.
And sometimes we can simplify things dramatically, reducing glucose checks, reducing insulin burden, and even transitioning to oral agents.
Patients love this.
And families do too.
Heart failure is interesting because not everything gets stopped.
Don't stop the diuretics if they're helping symptoms. Lasix can absolutely be comfort care.
But maybe the statin, maybe the high dose ACE inhibitor causing orthostatic changes, those might not still fit the goals of the patient.
And ICDs, implantable defibrillators, this is a big one.
People often don't realize that those shocks can continue at end of life.
Painful shocks during the dying process, that's not a peaceful death.
So if someone is M1 or M2, we should discuss deactivation.
For COPD and pulmonary fibrosis, symptom management remains the key.
Puffers stay, oxygen if it helps, sometimes low dose opiates for dyspnea.
And in chronic kidney disease, phosphate binders are a great example.
They can be very constipating.
Exactly. If a person is miserable and not benefiting meaningfully, we need to reconsider. That's the key message. Deprescribing isn't about doing less, it's about reducing harm.
If we had one takeaway for providers listening today, what would it be?
It's to pause, reassess, ask whether each medication is still helping this person live the life they want according to their goals.
This is thoughtful medicine, not cookbook medicine.
And honestly, patients and families are often relieved when we simplify things.
Particularly when someone finally says, we don't have to keep doing everything?
Exactly. Try medstopper.com, a free website where you can input frail elderly, you can input all their medications, and the MedStopper will actually highlight those which may actually be harmful and have suggested taper approaches to all the medications. For example, when you're thinking of putting somebody on Berdoac, even just pressing this calculator will take you to the CHADS2 VAS score as well as the HAS blood score, and follow this with the annual risk of stroke embolism and major bleeding, as well as number needed to treat. It isn't taking into account that most of this data is derived from a population of young people as opposed to people over the age of 75. Medstopper.com is a great resource. Take care, everyone, and maybe go review that medication list you've been avoiding.
Especially the pantoprazole that's been there since 2009. And remember, it's okay to deprescribe gradually.
And it's also okay to restart something if symptoms worsen.
Thanks for joining us for episode 5 of Val and Mark's M2 show.
One, two, three. Bye
Bye
for
for
now.
now.